We went from 13% error only down to 8.4% error with a static tensioner. So what I want to talk about for a few minutes is the next step in what I believe is the appropriate transition into soft tissue tensioning. A company in California called Synvasive has an articulated spacer that allows you to achieve up to 10 degrees of external rotation. The articulated spacer is pinned to the distal femur. That's the thickness of your distal femoral cut. And the tibia is grooved out in the back so that for your flexion gap, you really are only looking at your tibial thickness. We've started using both a mechanical and now a wireless force plate. This is clipped into a handheld device during the procedure. I just want you to know, though, that this will not probably be available commercially in terms of the sensor pad until the academy. We are able to select which knee, and the algorithm is we take the knee into extension. I can use the block as a thickness for my extension gap and do my releases, as you see here. I can then take the knee into flexion. This is the patella, this is the tibia, and with the patella reduced through a minimally invasive incision, I can dynamically change the external rotation of my femur to obtain equal symmetrical flexion gap balance. And this is what you see me doing. With this knob, I can externally rotate this. And this is very helpful in my valgus knees. When I'm doing this, I'm getting a force feedback on both my medial and lateral compartment with my knee in different degrees of range of motion. And you can see here, the medial is 4, the lateral is 2. Now these are not exact numbers, these are quantitative to each other. And with rotation of this, I can then achieve the equal balance and flexion. During a study we're doing now ongoing, I'm comparing the different anatomical align marks, and I'm seeing almost in every case there is a variation if I use the tensioner. This tensioner, once you've achieved the appropriate rotation, can be integrated with any knee system you're using, and the block can be pinned. And what you really want to see here is the appropriate rotation. So now you've obtained that, and you can go on. Dr. McAllister is now looking this and integrating it in the cadaver model with Cass, looking at as he rotates the femur and tracks this, what this is doing to his knee kinematically. And this will be going on to human studies. This is basically what we want to achieve. We want to achieve a well-balanced knee that obtains full flexion and maximal extension with good balance. So in my concepts of using the LIBRA, it's allowing me to obtain appropriate extension and flexion gap balancing prior to any femoral cuts. I haven't bought the farm here. I get real force knowledge with my patella reduced through now more minimally invasive incisions. It can be used with any of the knee systems that I use. I'm a large user of mobile bearing knees, and what this is allowing me to do is obtain the best flexion gap balancing to allow the theoretical benefits of the mobile bearing insert to maximize its function. And I believe it will have a greater role in valgus knees. I'm just going to show you a 2-minute clip here of a knee here. This is a right knee. Here's the patella here. I do most of the approach in extension where I find the soft tissue is not as tight. I elevate, I usually do most of these under a subvastus or a mini midvastus approach. I'm elevating the medial sleeve here to expose the VMO muscle. I usually palpate the superior aspect of my patella, and I make my midvastus snip there and come down through a medial arthrotomy. I release the anterior aspect of the fat pad as well as the medial collateral ligament to expose the knee. And then sublux the patella laterally, and I can flex the knee up now. And every knee is going to be a little bit more variable. I use this Inomed patella retractor to protect the patella, and I continue to release laterally, and I increase my incision as needed for exposure. I've now changed my surgical technique due to this tensor. I do my proximal tibia first, remove this, and sublux this out of the knee. I then do my distal femoral cut. Since I'm now mainly a posterior stabilized user, I release that as well because that will affect your flexion gap balancing. After we do our distal femoral cut, I now pin the Synvasive block onto the femur, which comes in different sizes. Once again, this does not matter if you're an anterior referencing or a posterior referencing surgeon. All this is an articulating dynamic spacer. The force plate gets clipped onto the handle. This is then integrated with the telemetry, as you can see over here on the right. And I compress this just to show that each load spacer is working. This is then inserted into the knee, and I can now take the knee through a range of motion. I first take it into extension, look at the force loads both in extension through a range of motion. With the patella reduced, I can now change my rotation and see what my loads are doing in different degrees of flexion. Once I'm comfortable that I have a symmetrically balanced flexion gap, I can now pin the Synvasive block, which then integrates into the knee system I'm using. I check this with my anatomical landmarks as well. Both my posterior condylar, my epicondylar, and my white side line. And the rest of the surgery basically is standard that most surgeons do. So I want to thank Synvasive for allowing me to present my initial 6 months data. We are going to be looking at our outcomes in bilateral knees using this on one leg and another, and then follow this both kinematically and fluoroscopically. Thank you very much for your time.